Dr. Rachel Brem is a professor of radiology and the director of breast imaging and intervention at the George Washington University Hospital in Washington, D.C. Dr. Brem is renowned for her work in advancing new technologies in early breast cancer detection. Her early work with breast-specific gamma imaging began during her tenure at Johns Hopkins Medical Center, where she led clinical studies that confirmed the efficacy of functional breast imaging.
I've been involved with the development of this approach to breast cancer diagnosis for 7 or 8 years, really since its infancy. It's been a very exciting road to watch the development of this extremely powerful and extremely exciting technology that has the potential to help all women. So initially, as is the case with all development, there were modifications to the detector, there were modifications to the design of the equipment. I think now we've gotten to the point that it is truly optimized for imaging the breast in that it allows us to image sub-centimeter lesions. We can reliably image 3-millimeter cancers. We've detected 2-millimeter cancers. We are now reliably detecting not only invasive cancers, but ductal carcinoma in situ. We are now looking at the data of those hard to detect cancers, the invasive lobular carcinomas, and in fact we have had 5 invasive lobular carcinomas, all of which were positive on breast-specific gamma imaging. So we're finding that the use and the application of this technology is increasing both by its design and by its ability to reliably image sub-centimeter cancers. Initially, scintimammography, which was some of the precursor approaches, used a traditional gamma camera where it could really only detect large cancers. And obviously, if you detect a cancer when it's large, the chance for cure is far less. We now can reliably diagnose cancers that are smaller than the diameter of a pencil eraser, which really allows the woman to have the optimal treatment and optimal chance for cure.
Scintimammography came about approximately 20 years ago during the evaluation of cardiac imaging with cardiolite. They would find lesions in women that would light up in their breast, usually greater than 1 centimeter. With the imaging of cardiolite, and therefore we progressed on to MIRA Luma, we would put the patient prone on the gamma table with a cutout. The machine would rotate around the breast and we would image the breast that way. Unfortunately, due to the spatial resolution and the distance from the camera, we were only able to image lesions greater than 1 centimeter, usually in the 2 to 3 centimeters, and therefore MIRA Luma fell into disrepute, and other modalities such as mammography, ultrasound, and MRI came to the forefront. Until recently, approximately 1.5 years ago, when I first saw the Dilon breast-specific gamma imaging, this machine was a lot smaller, a lot more breast-specific, and therefore, because it was smaller, the breast could easily fit into this machine, which had the flexibility to rotate 360 degrees and pick up lesions greater than 3 millimeters. The breast sits directly on the photomultiplier tubes, and we image it in both the CC, MLO, and ML views to have direct correlation with the mammogram. The beauty of the Dilon breast-specific gamma imaging machine is its flexibility. Not only is the machine small and mobile, but with the breast sitting directly on top of the photomultiplier tubes, it cuts out the dead space. The shield on top is a lead shield to permit just gentle compression of the breast. It's not like mammography where they have extreme compression. It prevents scatter radiation to the patient, but also just stabilizes the breast so we can get appropriate views.
The Dilon 6800 high-resolution, small field of view gamma camera was designed with ease of use and need for mobility in mind. The compact system can easily be adopted into your existing operation without a costly build-out, thus eliminating installation and facility costs.
When I first wanted to start performing these breast-specific gamma imaging tests, I had to find a location. And in our breast imaging department, we're short for space, as I'm sure most other breast imaging departments are. We looked around, and in our own department we didn't see any available space, but we saw another room that was used for bone density. And I was very pleased to find out that we were able just to roll the machine into that room and to be able to do the Dilon scans in that room with no special preparations. So the fact that it was easy to incorporate into our practice was a big plus.
The procedure is optimally performed in the breast center by a mammography technologist. Continuity of care is provided when one technologist is able to perform all imaging related to a patient. Additionally, by allowing imaging to occur in a woman's health or breast imaging center, patients are able to remain where they receive care, and practitioners are able to maximize care time and avoid outside referrals.
Well, in our practice, our mammography techs run the study. The injection of the nuclear medicine material is done by a nuclear medicine tech, but our mammography techs actually run and perform the procedure. That's really valuable, both in the sense of positioning, because they know the positioning, and patient comfort. It's the same person who is doing their mammogram is now doing their melanoma scan. So we have found a real high acceptance both by the patient as well as our technologists in performing this study.
The diagnostic capabilities of the Dilon 6800 are not limited to breast imaging. Other applications include the thyroid, pediatric imaging, and renal imaging, plus any other body part small enough to fit within the 6 by 8 inch detector's field of view.